Good afternoon, everyone. Hope you're all right. Hope you're good. Hope you can hear me. As per usual, I have my usual tech paranoia. My guests are waiting patiently in the lobby. Darren Finnegan and Becky Gray are joining me today. I've been looking forward to this since my good friend and colleague Nick Levidas, I always mispronounce his surname there probably, or is it Lividas or whatever? You won't mind that. But he suggested this episode and recommended these good people to me. And this show is something that is long overdue, really important interventions, especially in this time. Regarding public health, things like weight loss, alcohol and smoking management, that sort of stuff. And we all know it's important, but we all don't do it paid lip service. And so when people are doing good work and showing demonstrable outcomes in services, that's exactly the sort of thing we want to champion. And so I'm pleased that Darren and Becky will be joining me in a second. Thank you so much for all your participation on this week's shows. It felt like a big gap because of the bank holiday weekend. And so it's really cool that the shows that we've done this week have just had a massive amount of interaction, both live, during, and then after the fact. And so for those that don't know, this is a live stream, yes, and great if you can join at lunchtimes, but you can also, the video then exists after the fact in various different locations. Unfortunately, not cast to Twitter for some reason on this particular one, but it's on YouTube, LinkedIn, Facebook, etc. And so also, if you'd rather listen to it on audio, then you can find it on Spotify and wherever you get your podcasts afterwards, soon after we just upload it as an audio. So that's simple. But those that are tuning in live, please get stuck in and get involved. Any questions you might have about this, especially because some of the suggestions that they're making, this is all pointless unless you bloody act on it, right? That's my whole thing, my whole project is that you've got to then take some of these ideas and then have a go at moving them into your own local context. Okay, that's really important. So if you feel that there's things there that don't feel like they're implementable, or you've got questions that make them then feel more real for you and your circumstances, ask them. Please do let us know. And even if it's after the fact, I'm sure these guys will want to share that afterwards, and we'll find other ways, potentially even have them back on the show if we need to. So without further ado, let me see if in a couple of clicks we can bring Becky and Darren in. So let me hide my little frame. This is the safe one. Becky, you can hear and
Hello.
see me? Yep.
Yes, good. I can. I'm here. I've arrived.
That one's working, right? So then we've got now two Darren Finnegans. Could the real Darren Finnegan please stand up? I've got one video that's just popped up. Oh, we're getting feedback there. Can you mute us, Darren? Darren, I don't know if you can mute us or something, but it's screaming in my ear, and I assume that's also the listeners again. So we'll have to try that again. Becky, were you getting that squealing?
Yes, I was. Yeah, I don't think there is a big truck reversing where Darren is, but it sounded like it. So.
Absolutely right. So just gonna do a couple more tweaks our end, and also just make sure that the live streams are all working. But in the meantime, could you just start us off by telling us a little bit about what it is we're going to discuss today and what you guys have been doing? You heard my intro. I hope that represents it all right. Please do just give us a bit of a whistle-stop tour of what it is you've been up to.
Yeah, so it was a really good intro. So I'm quite new to South Tyneside service, actually. I used to work for Connect Health, but in London, in Camden. So I'm hoping Darren will pop on because he knows some of the stuff that was happening before I arrived. But already in the past 4 months, there's been a kind of big push towards kind of a few different pillars, really. So first of all, making every contact count. So obviously you can have a chat about that and trying to encourage staff to have conversations with patients about brief lifestyle interventions. So fitting it into our telephone triage, initial appointments, and in our reviews. So by that, obviously, we mean discussing kind of smoking cessation, alcohol, weight management, healthy lifestyle, exercise, and then obviously you can branching out towards kind of social prescribing and things from there. So South Tyneside, really, we've been very lucky in that the CCG have been very supportive of us kind of driving forward with kind of trying to get out there with the public health messages, lifestyle interventions. We've done a few kind of projects. Myself, one of the projects that I've worked on since I arrived is a waiting list project. So obviously with coronavirus, it was identified that orthopedic waiting lists have gone up and up. So one of the projects I've been working on with the local hospital in South Tyneside is a kind of information that gives a lot of kind of little tips and tricks on preparing for surgery, but a lot of that included the stuff we talk about in making every contact count. So the effects of smoking on healing, and generally preparing for surgery, exercise, diet, weight management. So we've got kind of quite a few projects going. Like I said, Darren's probably going to be the best one to talk about some of the other things, and especially the staff training that we've been doing as well to get everyone up to date.
Let's give Darren, let's pull one of Darren's streams in, see if it can behave itself a bit better. So hopefully. So yeah, for some reason that's still feeding back really strongly. Try another one. Darren, can you hear us on this particular one? We can't see you, but is your audio coming through on that one? No, the glory of complex tech. Sorry, Darren, we're still not able to bring you in on that. The interventions that you're describing, do you think it's reasonable what I said about how we sometimes know they're important, but we can't help ourselves but to pay lip service to them? And by that, I'm not necessarily meaning that we, it's like it's a shameful thing. Right? I'm not saying that, because it's sometimes hard, and it's sometimes like you open a can of worms, and there's a few different consequences that come from that, where it feels a bit socially inappropriate sometimes. So I just wondered, do you recognise that, and is that a barrier you guys have had to overcome?
Yeah, and I think traditionally probably the way we saw physio wasn't so much using these kind of getting involved in kind of the health coaching and that side of things. So there's been quite a change. So I find personally a lot of the younger people that come through are a bit more prepared for those questions, or might volunteer some of that information, but particularly that maybe the patients in their 40s and 50s that have been through physio, where things maybe are a bit more passive, a bit more biomedical, there's a bit more resistance there. And I think really those I guess those hesitancies though are ours as clinicians, and it's something that we need to work through, because actually I think we're perfectly placed, and particularly off the back of COVID, and we know mental health issues, we know people, a lot of people have adopted unhealthy habits to deal with the situation that we've been in. And we know how closely the mental health and physical health are linked with metabolic health, and then subsequently with outcomes. So I think as physiotherapists, we're in such a perfect position to have those conversations. Yes, okay, sometimes those conversations around weight management and things, do you feel you're a healthy weight at the moment, and being able to develop on that can be sometimes a bit daunting. But we've got to remember that these patients expect it when they go to a GP practice. And when you go to a GP, it's commonplace to talk about your smoking, your alcohol habits, your weight. And I would like to see that being commonplace with physio. So I'd like to see patients coming in knowing that they can talk to us about those factors. We're physio specialists, we're physical specialists. So
sure. How do you mitigate the risks of it feeling judgmental, even bringing that up? Or people thinking that you're making an inference of cause, aren't you? Like they're coming in with sore bits, and then the fact that you're raising those factors, sometimes they instinctively think they're inferring that that's the cause, whereas actually I fell down the stairs, like piss off.
Yeah. You do have to approach it very carefully, don't you? Because I think that for me personally, my emphasis is always on, we'll talk about the problem itself, and then when I explore those behaviours, it's an invitation to discuss that thing. So I don't think it ever works when you say to someone, do you think you're a healthy weight? Well, actually, no, I'm a bit overweight. Okay, well, I'm now going to give you all of this information. We're really going to talk about how your weight is a problem, which is, already we know there's a taboo with that as well, because people come in, don't they, and they tell us, oh, I've got knee pain. My GP told me it's my weight, but even if I lose weight, I've got knee pain. So we do have to be careful, but normally I will kind of invite them into the conversation. So say for smoking, say, you know, do you smoke at the moment? And they'll say yes. And I'll say, oh, is that something that, you know, you've ever thought of cutting down with or quitting? Is that something you've tried? And they might say, oh, well, yes, I have, and I've tried and I've gone back to it, or I haven't at all. And then normally I say, oh, the only reason I ask is because did you know that smoking can kind of affect your healing times? It can affect your tissues and how they kind of cope with loads. Right. And then kind of lead it in. So the way you ask it, I think, is very important. And then from there, people often say to me, I didn't realize smoking affected my tissue. I knew it affected my lungs, but I didn't realize. So you're asking it in a very genuine way for a reason, rather than, do you smoke? That's the problem, if that makes sense.
It's a great shout. I'm going to go into, and we'll try Darren again in a second, because I've just seen him pop back up, and hopefully we'll look like we're going to get somewhere closer. He's pointing to his ears. I assume he's not showing off new earrings. I think he's got some headphones in, so we're going to bring him in a second. About the sort of service level stuff, but also what you've just said there is a killer, is that when people, it's really genuine, because often we find that fascinating, don't we? Like, it's not that, it's fairly recent that we've come to realize just the overt physiological differences and changes that it makes with smoking and stuff. And I think that then it's easy for it to come across non-judgmental, because it's not, you know, we just genuinely like, who were to know, especially those that have been long addicted to cigarettes, are like, little did they realize some of that sequelae, and that's where it can become across as really genuine. So yeah, let's see if we can get Darren back in and go into some of those service level governance bits. But Darren, are we there?
Yes, we most certainly are.
Fantastic. Brilliant. Well, thanks for joining. I'm sorry about all that tech issue. So you've been hopefully still able to hear where we've gone so far in the conversation. And one of the things I really wanted to get stuck into really is if you could set the scene on the service level stuff. So Becky had said if you could point to what was as well as what is, but then also just start to speak to what it is that Connect supported you on, and what service level changes you've been able to make that others that are listening in that could potentially look to implement to take your lead.
So yeah, it's been a huge journey over the last 4 years, 5 years, particularly with myself. It's a case of been looking at, you know, we know the what's and the whys of why smoking, physical activity, weight loss, and alcohol conversations are really important, but we've never got down to the kind of how we do it at a service level, or even from a clinician conversation point of view. So it's been one of the building blocks where we've initially started this journey years ago, building up patient resources, being patient information leaflets about these topics as a soft touch approach, being like, these are the options. And then it's obviously over the last few years it's developed where social prescribing's become a bit more prevalent in the media and in practice. And from a service point of view, it's really got a rocket up its backside over the last year with the of Hal Brace, first of all, and obviously Nick Lividas as well. From a service point of view, we've mainly looked at the soft touch approach. We've also looked at building up the partnerships with link workers, and you know, we wouldn't be here having this conversation today if it wasn't for the CCG and the support being pioneering. Like they're chasing changes, which is brilliant, and supporting us every step of the way, which is exciting to hear and see.
Brilliant, because it takes for that support, doesn't it, for it to really break through. Your audio is coming through fairly clearly, but it's just a little quiet, Darren. So I know it's as basic as me just asking for you to speak up a touch, just so that you match our man and Becky's noisy volume. But otherwise, what I wonder is just how replicable do you feel that some of the changes that you're making, like how much of it is individual clinicians then just having brave conversations and providing signposting opportunities, and how much of it is a service level infrastructure change that needs to be inspired from bosses?
Yeah, and I think a good portion of it comes from, we all have the same time pressures in clinic, but ultimately time management isn't an issue, it's a prioritization issue. That's what time management is. And lucky enough, we have a senior leadership team who are prioritizing public health, social prescribing, and these making every contact count changes. Right. From a clinician perspective, we've obviously upskilled everyone. We haven't resting on our laurels thinking that every physio is really good at having weight loss, physical activity, and smoking conversations. So we've invested in MI training, invested in, obviously, with the help of First Contact Clinical, healthy eating, smoking cessation, and alcohol cessation training, as well as building it into the templates that we use. So then it's reinforcing it every single template that you run for a client or patient, that we're encouraging people to have these conversations. Because as we all know, MI, better conversations, and in a non-judgmental way, whilst asking permission. So the key thing is brief interventions. You need to ask permission. It's like if we're not, if we're just going head first into these conversations without asking the patient's permission, as Becky alluded to, they're going to put up their defenses.
Yeah, if the patient lets on some hints, and that then means, well, you crack your knuckles and say, well, you now qualify for my best sentence on weight loss, smoking, alcohol, other vices you may have, that I'm therefore going to just deliver my favorite line on. That is just not. It's not patient-centered. It's also something that doesn't truly offer a shared decision-making opportunity. One of the things I want to ask the audience, especially those that are tuning in live, and you can get stuck in, especially now that we've sort of stabilized our little tech issues. So thank you for your patience, those that are tuning in live. I want to ask you guys, what are your perceptions of this sort of topic? Do you find that easy? Do you find it easy to raise? If not, as many of you, from what I can gather, find these sorts of things tough. I know I do. What is it about them that's difficult? And therefore we can ask Becky and Darren as to how they overcome those, because I'm sure that they've encountered them too. It seems like they're not pretending this stuff's easy. They're just saying that on the service level, as well as their experience, they've then been able to overcome it. So please do let us know any of the particulars so that I don't carry on guessing. A few comments that have come in already. Thank you to Gemma, who said that it's a great topic for chat today. A lot of requests for us to visit stuff like this, so I really do appreciate you guys coming on. We've also got an undergraduate perspective from a third year here from Gareth, who said it's integrated in how it's integrated into the service. So I want to go there then just for a little longer. Is what do you feel is different about how these things are being integrated into a service, rather than them just being, make sure you do these talking points, which I think every service has been there. So what do you feel is different that seems to be cutting through and delivering quality outcomes as you're measuring them so far?
Yeah, and it's building it into the system. So we're privileged to have a data team behind us where we can actually say, yeah, we've had over 7,000 conversations about these topics since September, and we're not naive enough. We're not naive. We know that doesn't mean that everyone's going to stop smoking because of conversation about it.
Be nice.
Yeah, it would be. But we know that having the conversations is the first point, and then measuring that we're having them, and then it's refining and reflecting and making sure that we nail some of them topics, and it's not on us. It's a partnership. We need to get away and rethink the way that we deliver physio, and think that it's just us. We're going to go in, more problem solvers, and we'll fix everything and have everyone exercising every day and so forth. But back to the hows and the whats, it's a case of this journey started because we're like, how can we make a long lasting impact on the people and the population that we serve in South Tyneside? That's ultimately the question. And we're not firefighting, loads of MSK conditions. We know that all our health campaigns and stuff where we're looking at diabetes, long-term MSK conditions, think how we do this. And just a final topic on that is like how is looking for that segue in, and the segue now post-COVID at this moment is people talking about the quarantine 15 and putting on a bit extra pounds. It's like, I'm just curious to know, in terms of your weight side of things, do you need any support with that? So it's the ask, act, advise. Ask, do they need any support? Act if they advise, if they want the signpost, and act if they want referral on to specialist services. And that's my, just keep it brief.
The top tips. No, that's great. I mean, Becky, I'll bring you in on especially this point if we can, because there's a lot of comments coming in now across LinkedIn and Facebook, etc. of people saying about the weight being the most sensitive topic to approach with patients. And Joe Baxter's made a good point here where it feels like smoking and drinking, it's something that's overt that you can do. It's kind of more obvious in a sense, whereas weight just feels a little bit more personal, as well as the fact that it's a bit more subtle as to the reasons, sometimes overlapping with those other things. But is that something you've experienced either yourself or as a service?
Yeah, I think we've all had those conversations, haven't you? You know, you start up a conversation, you can see it going down this wrong path where someone's taking it personally. But actually, I think we've got a perception as well. We're quite fearful sometimes of having these conversations. But actually, when you open the dialogue, there's a lot of people out there that do want help. They do want to lose weight. They do want to make behavior change, but they don't know where to start. And actually, when you look at the evidence behind behavior change, we know it's not just as simple as saying, I smoke, I know smoking's bad for me, so I'm going to stop. That doesn't work, just telling someone to stop doing something. And I think in terms of kind of our service, where we do quite well is that we're very aware of what services are around us. We've got first contact clinical, got some weight management services, smoking cessation services. And really, as physios, we don't have to do it all. We have to plant the seeds. So, you know, we sow the seeds, and that's quite difficult because with time constraints, I think, like I said, I think when you're sowing the seed, you can't just shove the seeds on and just say, oh, you smoke, that's bad for you, quit smoking. You need to go into a bit more detail. But as we said earlier, the other thing is if you go into too much detail, then you're almost sidetracking the appointment and the knee pain that they're there for. So it's finding that in-between level. And that's where those services and knowing what's in your area is brilliant, because if you've got a social prescribing service who can focus on X, Y, and Z, social isolation, all those other things as well incorporated, fantastic. Use your services.
Yeah, I think that's a really interesting way of seeing it, because I think we've got to, our analysis of what the biggest fish to fry is quite subjective, but I think that sometimes our instincts are pretty good there, and sometimes it is worth, especially with the permission and they're sometimes inviting that on, it's worth going down that route, often because that technically is something that is a really key intervention to that presentation. Whereas if you balance that poorly, and it's something that is a factor, but it's not the burning factor that's affecting the questions that they have and what their hopes and goals are and expectations from that appointment, then that's going to go awry. That says how people get lost to follow up and how we sometimes then lose on a prem level. He also speaks to what Joe Turner said here, which is that she says a great discussion, but also there's a flip side that patients know there are wider issues and they're sometimes waiting for the clinician that will go there with them. That seems to speak to what you're describing there, Becky, where actually when we dip our toe in the water, it ain't that cold, and that sometimes we can just get stuck in. Is that based on both the experience and the data? Like, is that what's bringing to bear with you guys having done this work? Is that what seems to be coming up? And are there any deleterious consequences that are cropping up as well?
I think I don't know, from the data point of view, Darren can probably speak from that side a bit more, from just being a senior clinician that's doing the appointments on the ground. I do think that people are really receptive to these conversations, and because we are as clinicians being encouraged and pushed to have those conversations, even if they're uncomfortable for us or the patient. You'll soon know if someone doesn't want to talk about it, because they'll shut you down. And if that's the case and they say, no, smoking's my coping mechanism, I'm really stressed at the moment, I don't want to speak about it, that's fine. We move on and we don't pursue it. So yeah, I don't know, Darren, if you've got anything to add.
Yeah, and it's always been a personal bias of mine because I'm just interested in the area. So that's why I've always asked it, and developed a bit of an interest asking, talking about these factors, because personally, I grew up in a pub in Ireland. All I was surrounded by was alcohol, smokers, and inactive people, and it was just in my nature to talk to people about it. But in terms of from a experience point of view, people are very receptive to it as long as you don't push past that. Ask permission, brief intervention. They say no, right? We'll move on. That's it, and it's a non-judgmental approach, because this is a long-term change, and some of the evidence is around 7 touch points, where your shared decision making, and 7 touch points, that at the 7th point that's when people make changes in terms of their behavior. If they're hearing it from the GP, hearing it from us, hearing it from a couple of interventions along the way. And that's where some of the MEC stuff is going, training non-healthcare related people in these conversations, which is quite interesting.
Yeah, absolutely. I think one of the things I'd add there as well is that if you do it appropriately and subtly, even though there's not an opening there, if you don't, I'm mixing my metaphors here with openings or whatever, but I'm meaning like, if you don't burn that bridge, right? If that's something that you can then, a few sessions in, the rapport's then well built, you've not ended up sort of spoiling it by trying to be too forceful with trying to have those conversations that aren't particularly, the back and forth isn't forthcoming, then it may well be that when rehabilitating someone, they're starting to overcome some of the acute nature of their symptoms. They're then noticing that they're sometimes a little bit noticing I'm out of breath sooner than I thought doing these squats, right? That might therefore be a context in which it feels more comfortable for them, or they might even so often they'll invite that and say, it's making me realize how out of shape I've managed to get, especially in the context of which we've all been. Then that's the more appropriate thing, which you will lose that opportunity if you spoil it front end, right? If you get it wrong early doors and you're too clumsy there, although granted we've all got to make those mistakes, haven't we? Let's be fair. But it's just more if you become a bit of an ideologue on it, if you start to become a bit vociferous with those conversations, you're going to miss those other opportunities that are more appropriate, and they're just not going to emerge and present themselves to you, as well as the fact that the patients are probably falling off your list before you even manage to do that again. We've had some lovely comments coming in, including some from some of your colleagues. Andrew Cuff's backing your points here with regards to the data. He says what's more impressive is how at the same time period that the South Tyneside team has had over 7,000 making every contact count conversations, the patient experience measures have significantly improved. It's easy to do this badly, and then here I go. I always have to bloody zoom in and get my eyeglasses out to try and work out the rest of it. So I missed the bit. What's he said? Easy to do this badly, much more difficult to do this well, and you guys are smashing it. Thank you for sharing. Lovely. Thanks for that, Andrew. That's really interesting, because I think one of the criticisms that could get leveled at someone that's just thinking about this without reviewing the objective side of it is that that's all well and good doing it, but the patients aren't going to like it. That's not what the data is showing. Is that something that either of you, if you're honest, thought might be an unintended consequence of this, or did you always have the confidence that you were always going to nail it and do it well?
I had lots of reservations about it. Because, over the last few years, that's been my main area of focusing on the qualitative feedback and feeding back to the team. And it was we've always done quite well with these conversations, normal conversations in the region. But when we've made that shift, there's been that change, and I didn't expect it, to be perfectly blunt. But yeah, we would have expected a general drop off a little bit, because it's a bit of expectation violation. People coming in not expecting that conversations, and then we're going off on a tangent. But because we've focused on the upskilling the team to have the conversations, that's why I believe there hasn't been that negative consequence.
Absolutely. Lovely contributions here from Gareth Ockenden, who's saying now, and Becky, I want to bring you in on this because it speaks to what Darren's just said there about perception and sometimes our own. I love it when it violates our own expectation there. There's nothing more spectacular than when your expectations are then, especially because we know how biased we are, that sometimes dictates the outcome. It's that sometimes our reservations are what then colours the outcome, whereas when something like this is so strong that it challenges it, it's brilliant. Gareth's then making a point in that perception case, if it going a bit further in terms of patient expectations with regards to physio. You said about being a hands-on profession and the patient appointment expectations being similar and expecting that. Do we feel the information carries less strength with patients when it's us giving it instead of a GP or doctor? What do you reckon to that?
So I think, again, it's probably about actually where we are at the moment with physio, where we've come from and where we're going. So I think probably for some patients, yes, they expect those conversations from GPs and don't expect it from physios. But something I feel strongly about, and why we're keen to come on here and talk about it and push it forward, is that we can change patient perception, but it's going to take time, and we need to be going in a similar direction. So, with MSKR and the reforms and things like that as well, it helps. It is right. It is a difficult conversation to have sometimes. But the other thing that I think that might be a bit of a catalyst for change is with COVID, with so much of it being virtual, people have had to start to change about the way they thought about physiotherapy anyway, because a lot of things have been virtual. And I've had patients that have said, I didn't think you could virtually do physio, but you can. And actually, virtual appointments give us this really amazing opportunity to start to build on these conversations, because we haven't got the hands-on skills when we're on a telephone, but we can focus on those other lifestyle intervention things. And I think someone on the chat said they're a student as well, and that's something that I'm hoping with virtual placements, Connect running virtual placements. I hope students are getting that education, whereas before, probably in clinic when I was a student, it was all get in, assess, get your hands on, let's do that. And these conversations kind of took a sidestep, but now they can be at the forefront. So it's changing. We've got to push for the change and keep going.
Well, I think that's something that a recognition, as well as both in terms of us giving the sort of reflections on our own cases and caseloads, but also then the data backing that up, and no doubt being able to then replicate that en masse as you guys are doing with thousands of interventions, means that we can back ourselves to know that that can be a powerful intervention. It's not an aside. It's not a hopeful, just give them a business card that's got the right link on it, a signpost. It can be a bit more involved in that where appropriate. And I think that's going to really back that contemporary practice that we're promoting. And I agree, it really does fit into the wider agenda of raising standards and reforming MSK practice. So, but of course, I would say that, wouldn't I? So, I mean, you're all, I mean, I love you as an audience, but you're all buggers for doing this, right? Last 5 minutes, I'm over time, and your brilliant comments start flooding it. So I'm going to go for another couple of minutes, but I've got to then wrap up. But anyway, thank you so much to Claire for this. A great point about patients are often in a cycle of sleep, pain, limited energy to exercise, leading to the diets and stuff. And you end up with this funny cause and effect cycle, don't you? And I think that that's something that it's really helpful for us as clinicians to recognize that these things aren't, it is chicken and egg more often than not, right? It's not the fact that it's like, well, those bad decisions have led to then these poor health outcomes, and therefore just nip that in the bud. It's almost like a beating stick on people. Of course, it's more than that. And that's something we just need to sort of grow up a little bit on. And sometimes the physio perception of sort of Mr. and Miss Motivator sometimes can play against that, can't it? Darren, sorry, you were going to come in on that, mate.
Yeah, I'm just going to come on that sleep comment, because as we were saying, we almost want to build on, it's like building blocks. So if patient's coming in and their main focus is getting their sleep better, and we give them the tools, strategies, whatever to help with their sleep, then that's suddenly a building block that you're positively building on. And then it's a case of, then the conversation goes to smoking or alcohol or physical activity. And then you just keep on building and building. And ultimately with the brief interventions, and as Becky alluded to, with the undergrad side of things, we need to start at grassroots, and that comes from helping kids in school with the right beliefs and right understanding of these factors. And that is a project in the background that we're looking at, getting involved in schools, and at the undergrad level, in terms of teaching these things, health promotion, and teaching the MEC stuff, and to put our hands up. Like, we're not claiming we have anywhere near the right answers for all this stuff.
It's ongoing, isn't it, right? If we just delayed that gratification for, let's just wait for everything to be finalized and stuff, and we'll miss the opportunity to start inspiring that change, which is where the data will come from. So we've got to continue to do that. But yeah, we're not promising that this is the answer, but it's it's moving in the right direction, and we're backing that with both the subjective and an objective analysis.
Yeah, we'd love people to come in, reach out, contact myself, Becky, Hal, Nick, because we just want to help develop this. This is our focus, and we want to lead with humility, first of all, curiosity about where this could go, and then actually just build on that, because ultimately that's our focus and our priority, working with the great team that we have. And it's enough to say none of this would have been possible without them. So.
Yeah, for sure. No, that's a great point and a lovely place for us to finish. Nick, who we mentioned earlier, definitely knows how to get me to pull a comment up by using a phrase of which is, of course, central to MSKR's manifesto for reform. If you haven't checked that out before, then please do look at mskreform.org.uk and download the free PDF, either in long form or summary, which explains a little bit about what some of the structural level reforms that would support work, such as what Becky and Darren are talking about here, that of course we did in conjunction with Connect Health at the time. But he said, if not us, then who? And if not now, then when? Absolutely, the mantra in which we all need to remind ourselves of is that essentially we are the workforce in which we can instigate these changes. And sometimes it's easy for us to sort of shake his fist upwards and assume and hope that things might change from the top down. But essentially, it's amazing what we can do as a grassroots community, then trying to and appropriately testing the interventions of which we then deliver and change. And you've been a perfect example of that. As the project emerges, I'm going to challenge you on air to give me an answer and say you will come back on the show and tell me about any updates, and you and the team know that you're welcome for this platform and any of ours for us to shout about good work, but also for us to be honest about the fact that this stuff is appropriately challenging some of the dated interventions of which we need to also try to rid ourselves of. And it's only if we can elevate this stuff to know that it is credible and it makes the difference, and it's not a second poor cousin to manipulation and other treatments of which might feel a bit trendier in any given moment. We need to recognize that that balance of conversation needs to continue to happen. And thank you for joining me to discuss it. So it's been a real pleasure.
No, thanks for having us. It's been great.
No bother. Take care. And thanks a lot, everyone. We'll see you next week for more Chewing It Over. But for now, I'm going to hopefully hit a button. It's going to play a video, and then we're done for the week. So bye, and we'll just awkwardly wave until it does.